right, welcome back. It's about 25 minutes past the top of the hour. Time for our first discussion tonight, and it's all about health. Dr. Patrick Amoth, the Director General for Health in the Ministry of Health. Thank you so much, Dr. for coming tonight.
Thanks, Ken, for having me.
It's good to see you.
Good
it's been a while.
you
You know, I stopped going to the field. We don't meet anymore.
Good to see you too.
But you are doing a good job, I hope.
Finally,
you've settled after
Very
5 years. Good. So let's settle the matters tonight also, Daktari.
Thank you.
And let's begin with the elephant in the room. This is about the Mpox. What is the situation of Mpox in the country? Are we discovering new infections as the government moved further to protect Kenyans? And are Kenyans really taking heed what the ministry is saying?
Thank you for that question. Mpox was declared a public health emergency of continental security by the Africa CDC. Then the subsequent day, on the 14th of this month, declared a public health emergency of international concern, meaning it's a great public health threat, and that requires coordination, global coordination and regional coordination. As a country, we have recorded 2 cases of the virus. And the first case was identified, officially confirmed on 31st of last month. And the second case is a few days old. That was also a truck driver who had come from the Democratic Republic of Congo, the epicenter of the disease. What we have done as a country is, of course, to be able to activate our Public Health Emergency Operations Center. We have enhanced our coordination process through the incident management structure, meaning we have a structure as to how information will flow all the way to the head of the policy head of the ministry, the cabinet secretary.
Okay.
We have also heightened surveillance at our ports of entry, and that is how we are able to pick these 2 cases. The first case was picked, of course, in Taveta County. The second case was picked in Malaba County.
And what is the state of these 2 patients?
The first case, of course, made full recovery.
Okay.
He's out and about doing his normal business. The second case is still in isolation, but is in stable condition. We are hopeful that he's going to make full recovery.
We keep telling Kenyans, Daktari,
Yes.
that Kenya is not out of the woods. The fact that we have only 2 cases,
Yes.
you should even be more vigilant. Is that the message that you still...
That is the message that we need to do, to take out to the public, that we stay vigilant throughout until we de-escalate this situation through the Africa CDC and the WHO. Taking the corrective measures, the appropriate measures, including looking out for anybody with signs or symptoms of Mpox disease, avoiding unnecessary travel to the epicenter in the DRC. And if you have to travel, then you have to take the necessary precautionary measures, avoiding unnecessary contact with people exhibiting symptoms. And of course, if you get into contact with somebody exhibiting symptoms of this disease, is to be able to go to a health center for assessment by a qualified healthcare profession.
Great. Now that that is out of the way, we had the other day there would be another health crisis. I don't want to talk about that fast. Let me talk about the social health insurance.
Yes.
This is a new phenomenon. You know, at the back of my mind, I still think of National Health Insurance Fund. So tell us tonight, why the change, and what is this likely to benefit Kenyans? The
change, first of all, let me start, Ken, by telling you that NHIF has done a good job in the many years of its existence. But if you look at the architecture of NHIF, the way it was designed for payroll employees like me and you. And that only constitutes 20% of our population. 80% of the population who are non-payroll, but who are involved in economic activities, generating resources left, right, and right center, are not catered for by NHIF. So the move towards social health insurance is to be able to ensure solidarity, ensure pooling, so that these people in the non-payroll sector then can also be able to bring in their resources so that we can be able to have a sustainable financing mechanism for financing our healthcare services need. That will also come with what we call cross-subsidization, that the young will be able to cross-subsidize the old, the healthy will be able to cross-subsidize the sick, and the rich, those of us who are at least have something, we'll be able to pay for our brothers and sisters who don't have anything. That is basically the principle. And the change from what NHIF was also doing is in terms of the governance structure, like Operation OPEX for SHA is capped at 5%. For NHIF, it was more than 10, 12%.
So it's come down.
It has come down, meaning the resources are basically being used for strategic purchasing of the healthcare services.
But you brought in more people in.
No, we are not bringing more people, yes, in terms of contributors. Yes, in terms of contributors.
The
more people,
yes.
The cake is bigger, but the cake is basically being used to be able to serve the people rather than go into people's pocket in terms of...
that was a huge issue.
A big issue.
And it dogged NHIF.
For a very long time.
How have you dealt with that in this new dispensation in court?
By simply putting it in the law, and therefore we expect the management of the Social Health Authority and the oversight board that is concerned, ensuring that those things are strictly adhered to as prescribed by the law. And of course, we'll also be able to have the other layers of governance coming in when the auditors come to check and ensure that you have actually kept your operational expenses at 5%.
DG, the problem in this country has never been the law. It has always been the attitude and the people. How are you dealing with that? Because the laws, we are not short of laws.
We are also trying to remove a lot of the human interface in terms of processes of Social Health Authority by automation. If you look at, like, for now, the process of pre-authorization, you go to a hospital required to be treated, and somebody has to look through your papers manually. We want to make that seamless. The way you do your M-Pesa transaction, you don't know who operates that system. You only key in your data,
and the system responds.
It responds.
And that eliminates.
That is what we want.
How much money in your mind, because you've been in the sector for a long time, did we lose? Do you have that figure in your mind? Did we lose and you're likely to save with this one? Do you have that figure?
I may not have the actual figure of actual money lost, but I believe we can be able to have substantial savings by investing in this ICT platform.
Okay, so this is supposed to help Kenyans gain. There are several packages that you have tailor-made, and you're hoping these packages will make Kenyans gain. Take me through some of those groundbreaking packages that you think this is definitely a game changer when we adopt this.
First of all, Ken, NHIF previously was one major scheme, but with some small schemes within it. In Social Health Authority, what we have are three funds: the Primary Healthcare Fund, we have the Social Health Insurance Fund, and the Emergency Chronic and Critical Illness Fund. The Primary Healthcare Fund is basically supposed to be fully exchequer funded. Okay. You don't have to pay for it. The only prerequisite is that you register for SHA. Once you register, you go to a primary level facility, a level 2, level 3 facility, you should be able to get service. And the range of services spans all the way from promotive, preventive, curative, rehabilitative, palliative. So the entire continuum of care, you'll be able to get that whole range of services.
And the only need is register for SHA.
All you need is registration for SHA.
Exchequer will pay for it.
*147# or www.sha.go.ke.
That's the first primary.
That is the first departure.
Yeah.
For the first time as a government, we are putting our money where our mouth is, which is promotive, preventive, because curative healthcare is a bottomless pit.
Has not worked.
It has not worked.
It has not worked, let's be honest with you.
Yes, so this is the only time that we are going to have this paradigm shift, focus more on promotive, preventive health, to see that we can be able to prevent most of these cases. But if then we pick you up, then we'll be able to take care of you along the referral system up to the level 6 super specialty hospitals.
Okay.
Number 2, if you look at what was in NHIF and what is now in this, look at, for example, renal services.
That's for kidney patients?
For kidney patients. We have traditionally offered 2 sessions of dialysis.
Under NHIF?
Under NHIF, at a cost of 9,500.
Per session?
We have increased that one to 11,650, but with an option that if you require a 3rd session, on the prescription of a specialist doctor, nephrologist, you can be able to have a 3rd session without co-payment.
So you've increased the money?
Yes, we have increased the money.
And opened it up?
But also opened the space so that if you require this, then you'll be able to get it at no cost to you.
Okay.
Number 2, before you go for a renal transplant, a kidney transplant, for example, you need a series of tests between you and the person who is donating the kidney for you. We have catered for that to the tune of 150,000 shillings.
Per patient? What was the previous figure? Was it even there?
It was not there.
So this is a new one?
This is a new one. A total new package, 150,000. We are also going to cater for the donor nephrectomy, removal of the kidney from the person donating, Previously, that was not there,
So you paid
at
for it.
168,000 shillings. But we have also increased the cost of the payment for transplant from 500,000 shillings to 700,000 shillings.
Oh, great. Okay.
Something again close to the hearts of Kenyans is Linda Mama.
Yeah, I'm going to talk about Linda Mama, but I'm reminded that there was a directive for students to register. Before we go to Linda Mama, what is the state of registration? Did you hit the deadline of Monday? Did students register, or the teachers' strike disrupted this?
Teachers' strike disrupted this, but registration is still an ongoing process.
It's open.
And I think we have also changed our communication in terms of the registration process. Is the parent to be able to register and add the student as a dependent. It's not the student to register. So
Okay.
me, as a father to a child in school, I register myself, then I add my son or my daughter as a
to that
dependent.
system.
Yes.
And they stand to benefit from this.
They stand to benefit from 1st of October when we officially
There's money.
flag off.
There's money, Daktari.
Money will never be enough, but we'll be able to start with what we
How is
have.
the contribution that you want? Because it's
I
important
want
to
you
give this money.
to contribute your 2.75%.
For my salary?
Yes.
Daktari,
As I do the same.
talk to me about Linda Mama, Edu Afia, and all those funds. Where are they and how do they fit in this?
Linda Mama is very close to our heart. As a country, we have made great progress in terms of maternal child health. However, challenges still persist in terms of disparities from one area to the other. If you compare rural, urban, if you compare the northern arid lands and the other parts of Kenya, maternal mortality is still a challenge. One of the barriers and contributors to maternal mortality, of course, is financial access to healthcare services. That is why Linda Mama was introduced. In the share package for Linda Mama, the cost of delivery has moved from 5,000 to 10,000 Kenya shillings across board.
Across board.
Be it at a level 2 dispensary, or if you go to the top private hospital, Nairobi Hospital will pay normal delivery, you are going to pay 10,000 shillings.
Normal, okay.
Yes, cesarean section, we have moved from what we used to charge from 5,000 in level 4 facilities to 17,500 in level 6 facilities to a flat rate of 30,000.
Flat rate. It doesn't matter where you are.
It does not matter where you are. The choice is yours.
Yeah.
Wherever you go, we commit that if you are registered and you are a contributor to social health insurance, then we are going to pay that.
Okay.
However, if you are not able to contribute because you are an indigent or you are vulnerable or marginalized, then through the proxy means testing, we are able to identify how much money you generate, and the deficit or the difference will be paid for by the government to ensure that you are not disenfranchised from receiving healthcare services.
Okay.
The other thing that was not covered under the Mama Ken and which is critical is that sometimes you go to deliver, you think that everything is fine, the baby is fine, then a complication develops. All of a sudden the mother starts bleeding after the doctor gets the baby out. That is what we call hemorrhage. This was not catered for under Linda Mama. Now all complications related to the mother and the baby are catered for in the social health insurance package. Also, all the antenatal services plus the postnatal services are catered for, including ICU, newborn ICU, HDU is catered for under this package. Okay. So it's a totally enhanced package from what we had in NHIF.
Okay, we're running out of time. We have about 2 minutes, but there are still more important questions here that I have to ask you. Are you envisioning any challenges with this registration, or it's smooth? Do you think there will be challenges here and there?
Definitely there will be challenges.
What would they be, and how do we correct them?
One of the challenges, of course, if you are using this platform, the ICT platform, is connectivity. In terms of discussions that we have had with the vendor who is providing this service for us, at least we envisage that we are going to have challenges, especially level 2, level 3 facilities. Number 2 is because of the limited infrastructure, especially at the primary healthcare facilities, the dispensaries, and the health centers. The other challenge that we may be able to have, of course, is in terms of human resources for health. Once we launch this, we know definitely there will be a surge in terms of numbers. Where the human resource for health capacity is limited, then there could be delays or long waiting times. The fourth challenge, of course, in terms of health products and technologies, We have had a challenge in terms of our remittances to NHIF. We have not paid all the facilities, but we are working overtime to ensure that NHIF is given money to be able to settle the dues to the providers so that they can continue to provide services.
It was a smooth transition, or you're transitioning smoothly. There are no...
There will be hiccups here and there, but we believe that working together with all the stakeholders, we should be able to address them with a common understanding to wananchi that these challenges are going to crop up during this transition period, but working together, we should be able to surmount the challenges.
This is a new discourse, and it's right now just permeating in the society.
Yes.
How would you, as we end, how would you want Kenyans to contribute in this discourse? Because now the Constitution demands that before you implement such a thing, you have to ask me.
All these processes that we have undertaken, including the development of this benefits package, must involve all the stakeholders. The people of Kenya must have a voice in it. And what the courts told us is that it's not a mere voice, it's both in quantity and quality. Meaning when we have these discussions, we must be able to take into consideration the views of the public and actually incorporate them in our processes. So one of the things that we want to appeal to Kenyans is that they should be able to go out there. We are going to publicize all these things. Our package is explicit. We state that this is what you are entitled to. When you go to that service point, demand for that service. And we have dispute resolution mechanism, complaint mechanisms embedded within that structure, including the regulations that we established. Please, if you feel that you have not received what you have what you are entitled, go and complain and make noise so that you can be able to get value for your money.
In 1 minute, Doctor, I need to let you go. Medical tourism, now that you mentioned renal and all that, how are you dealing with it? Because there's a lot of people still going out of the country and they think there's better healthcare out there. It's expensive. Sometimes it's the doctors are more reachable than in the country. How are you dealing with that medical tourism? Just in a minute. I know it's a long discussion.
And you have given a very good example, that one of renal. In fact, that is, we have the East African Kidney Institute, a center of excellence. We want to be one of the centers for renal transplants. Instead of one hospital doing 2 or 3, we are saying, why don't we combine forces? MTRH, Kenyatta National Hospital, Nairobi Hospital, Medical Hospital, all these hospitals. Why don't we come together and collect all these patients together, assess them together, say we are going to do this transplants in Nairobi for this 1 week. That way we can be able to create that demand. Our doctors will also be able to gain the experience, and that will ensure that we can be able to create medical tourism in our country. Already we have started Kenyatta University Teaching and Referral Hospital in terms of cancer. We are receiving patients from South Sudan, from DR Congo, from Rwanda, and I believe this social health insurance will be able to create a good pool of resources for us to be able to enhance our capacity for medical tourism.
Now that you've said that, this is just for Kenyans. If you're not a Kenyan, no, it's only for Kenyans.
So long as you reside in Kenya, whether you are a refugee, if you have an alien certificate, even if you are a foreigner, so long as you can be able to register and make a payment, it is to ensure that everybody is on board.
Daktari, asante sana. The test is in the eating. Let's see.
1st of October.
1st of October. Asante sana. Dr. Patrick Amoth speaking to us tonight. You need to do what he says. I can't add more. I need not belabor on what he has said. Time now for another break. Remember, the top of the hour, we have Professor Wajakoya in studio with us. Stay with us. And latest research